Doing a volume-oriented IPPB treatment, I would either attach it here and monitor my exhale volume, or put the right respirometer on the inspiratory limb and monitor what their inspiratory volume is. I want an inspiratory capacity. That's the volume that I'm trying to attain. If I don't know, I can also utilize something where his tidal volume is increased 2 to 3 times what his normal spontaneous tidal volume should end up being. So I'm going to have him go ahead, and we can use some nose clips so he doesn't leak out the nose. And have him put his mouth tightly around the mouthpiece, take a small breath in, and passively allow it to inflate his lungs. And again, I would use my pressure control then to increase the volume that is there. So he's going to take a breath in, remain passive to it, and allow him to fully inflate your lungs. When your lungs are fully inflated, hold that breath for a second before you blow it back out. So in the case of using this to treat atelectasis, the concept is it's not only the increase in volume, but it's holding that breath to have that volume allow the gas to displace around it. I continue this therapy until the nebulization stops, at which point we have the patient take a deep breath and cough and assess the patient. During the therapy or prior to therapy, I would assess his respiratory rate, his heart rate, and then after the therapy, we would go ahead and reassess everything again. Side effects you want to watch out for are the tingling in the fingers, secondary to hyperventilation. He's probably feeling because he's breathing kind of fast there. Remember, even though his rate is not seeming like it's a very fast rate, those volumes are increased significantly. So the overall minute ventilation is elevated, and you're going to end up having hypocarbia develop. Okay? Are we feeling okay? Feeling dizzy? No. You're a liar. Like a second. Okay?
You feel expanded?
Question.
Can you explain again what is fixed and what is variable on the
Okay,
machine?
very good. This is a pressure-based breath. With pressure-based breath, pressure is always a fixed value. Okay. In this case, because I'm setting the flow is also a fixed value. In pressure-based breath, pressure is always fixed, volume, flow, and or time are always variable. If you remember, flow is nothing more than volume per unit time. So in this case, if I'm fixing the flow rate, I'm varying the time. So in the case of IPPB, because flow is fixed and pressure is fixed, the variables become volume and time. As I increase the flow rate, I slow down the inspiratory time. I also, in essence, slow down the volume that is delivered because it's reaching that target pressure quicker. This is triggered on through pressure, through our sensitivity side. He generates a small negative pressure. It's going to go ahead and move the magnet away to the point where it triggers itself on. When he then takes a breath in, as the pressure increases within his lungs, it's fed back through to this point, and when this pressure increases enough to push that away from the magnet, it cycles itself off. So it's pressure triggered and pressure cycled. Okay. If I did not see a large enough tidal volume, I could do one of two things. I could decrease the flow, so it takes longer to get to that pressure, in which case you probably will increase the volume that is delivered, and or I could increase the amount of delivery pressure that we end up seeing, which is typically what we end up doing. Again, if I'm looking and I'm not seeing the inspiratory capacity that I desire, those are the things that I would end up doing. If I saw too much, and especially if he was complaining of hyperventilation syndromes, I could do the opposite. Increase the flow, decrease the pressure to be able to accomplish it. Better? Questions?